So starting with this heart, we can see that the apex of the heart lies to the left. We can see that there's visceral or thoracic cytosolitis because there's 3 lobes of the lung on the right-hand side and 2 lobes of the left lung. If we turn the heart around to the back, we can't really see the branching of the trachea. However, we can see the esophagus, which descends on the left-hand side. So most likely there is abdominal cytosolitis also. Looking at the growths outside of the heart, we can see that there's cardiomegaly, with the anterior ventricle being rather dilated compared to the posterior ventricle. And when we open up the heart, we can see that the right atrium is very, very dilated. And we can see that there's pectinate muscles, which run from the appendage all the way around. This is the annulus of the tricuspid valve. And then we can see, this is the septal leaflet of the tricuspid valve, which you can see is rather displaced towards the apex of the ventricle. And you can see that it's tethered down. And when you compare this to the anterior leaflet of the tricuspid valve, it appears rather normal. And you can see that there isn't any tethering or any displacement of the valve. So this would be typical for an Ebstein's anomaly of the tricuspid valve. So there's atrialization of the right ventricle. And so even though the tricuspid annulus is here, the effective opening of the valve is much more inferior, so it's more towards the apex of the right ventricle. So then if we continue on the right ventricle, and we can see that there is a normal right ventricular outflow tract. So this is the right ventricular outflow tract going to the pulmonary artery, which goes to the left and right. And then looking at the left-hand side of the heart, it appears normal. So this is the left ventricle, which forms the apex, the left ventricular outflow tract here, the aortic valve. And we know this is the left ventricle because of the fine apical trabeculations when you compare that to the right ventricle, which has more coarse apical trabeculations. So in summary, it's concordant AV and VA connections with Ebstein's anomaly of the tricuspid valve and a patent right ventricular outflow tract. In the second case,
Yeah, Omar. Yeah.
It's important for clinical issues, ASD or intact atrial septum.
No, there was no VSD.
ASD.
Oh, sorry, ASD. One sec. Yes. It's a secundometrial septal defect.
It's very stretched foramen valve, Omar.
Sorry?
It's a very stretched foramen valve with big communication between the 2 atrium. Also, the RV myocardium is very thin, especially at the RVOT part. Yeah, here. This is very, very thin. Sorry. Where is the RVOT?
Oh.
Yeah. Yes, we expect normally with very severe Ebstein's, you have very thin RV wall, and sometimes that is also the problem why you can't generate enough output. And sometimes you might have to go on a 1/2 ventricle kind of pathway because of the RV itself is thin, although you can restore valve competence, but the myocardium is not enough to function as a pump on its own.
I want to ask the pathologist, when can we say there is an UL anomaly along with it? Because when I saw this muscle, I thought of it, but I didn't see in my life more than 2 times.
I don't think I have experienced any typical case of Ull's anomaly. Just the very thin, but usually they have a kind of thickness of right ventricle.
Okay, so then moving on to the second case. And we can see again that the apex of the heart points to the left. And then the striking thing on the outside of the heart you can see is that the right ventricle does not reach the apex, or the anterior ventricle, I should say. And turning the heart to the back, so we can see that this is the right atrium, which is connected to a small hypoplastic right ventricle through a very hypoplastic.
Can you all see the tricuspid valve?
This is the anterior leaflet of the tricuspid valve and the septal leaflet of the tricuspid valve, which is very small, hypoplastic and dysplastic with very short cords. Then when we move on to look at the right ventricular outflow tract.
And also, I think the inlet is very shallow. It just stops there,
yes.
and it doesn't extend to the apex. There is no apical component to the RV, I think. I think we may want to compare to the left mitral valve. See how small this tricuspid valve is, and when you compare that to the left side, the mitral valve.
So the left ventricle reaches the apex.
And also the mitral valve is a lot bigger than the tricuspid valve.
The normal.
Can you all see that?
The normally formed mitral valve. When we look to the outflow tract of the right ventricle, it looks like they've had an operation which looks like a transannular patch going across the right ventricular outflow tract into pulmonary artery. Our main pulmonary artery is going to the right and left. And the other thing that this patient has had is a BT shunt, which is going from the brachiocephalic artery into the I suppose main or right pulmonary artery. And there is no ventricular septal defect in this patient. And at an atrial level, I'm not sure. It's hard to tell in this sample. The left ventricle is normal. So in summary, this patient has probably pulmonary atresia with an intact ventricular septum. He's had a transannular patch and a BT shunt.
Yeah, the coronary arteries.
Oh, and the coronary arteries are normal.
We don't see a big dilated coronary arteries, both anteriorly, also posteriorly, circumflex. And the other thing is that when we look posteriorly, we can see the confluence of the primary arteries and where the shunt is connected to. Yeah, so that is, the shunt is probably bigger. The shunt is bigger than the branch pulmonary artery, slightly bigger than the branch pulmonary artery. So they tend to have very small pulmonary arteries in these patients, and shunting it in the neonate might be a problem. But this patient doesn't have coronary sinusoids, although it is basically a unipartite right ventricle with probably most likely to be a very hypertensive right ventricle. Anything else you want to comment? No. I think there was another specimen on the table which has very big dilated coronary arteries, which is nice to show, but I think these are good examples of one PAIVS, number two, the typical classical Ebstein's anomaly, and both are probably neonatal specimens, and these are both very high risk patients for any surgical procedures.